we just think about it, patients getting first a screening CAT scan, then diagnostic studies, PET scan, brain MRI, and other EBUS procedures, et cetera. This is so complex, so difficult for a patient to kind of work through. So, Mary, if I may ask you, you mentioned patient navigation already. Timelines of care, getting patients to starting treatment is so critical. Where does that navigation come in, and how does that make a difference?
Yeah, it actually starts even before the patient is diagnosed. We see the patient kind of coming down the pathway, that a suspicious nodule, or through lung screening or the nodule program. We presented them at tumor board, and so we already kind of have this pathway set up. When we see the patient and we give them the diagnosis, that navigation with the patient happens right then to be sure that, for them to go to the surgeon, we need those PFTs. We get cardiac clearance on them, and we need to get it done very quickly. So having a strong multidisciplinary team and our navigation team to walk with that patient through that process is incredibly important. And the timing is important. We want to be sure that it's done at a timely time.
Fantastic. So you mentioned the multidisciplinary team. Yeah. So maybe I can ask Momen and Jay just to comment on, so what is the critical role of that team, and how does your specialty kind of play into maximizing the benefits from our tumor board, from our multidisciplinary clinics?
Yeah, definitely. I mean, I can't imagine practicing without this collective wisdom of the multidisciplinary team, thoracic surgery, radiation oncology, thoracic oncology, pulmonary radiology, pathology. Really a big team. It takes a village. One thing that I really believe in is co-location of clinics. So we try to have clinics, some of us at least, in thoracic surgery, interventional, and oncology together, so that we can consult with each other. We can see add-on patients quickly, between the different specialties. And then the other thing is the multidisciplinary discussion, which is extremely valuable. And in that, I love that, the famous saying, if you have a hammer, everything looks like a nail, right? So we want to avoid that. Mm-hmm. We want the collective wisdom of the team. What is the best for that patient? Is it surgery? Is it radiation? Is it neoadjuvant before surgery? Is it adjuvant? And so all these, discussions are so valuable for our patients' best outcome.
Great. And Jay, you don't have a hammer. You have a lancet or a robot. So tell me, I heard from you that you guys have multidisciplinary clinics, regular tumor boards. How does the surgeon kind of participate in those, and how do you make sure that you use the knowledge base of the other specialties to make sure that you're making the best decision for your patient?
Yeah, so our setup at UCLA is that every Friday we have a multidisciplinary thoracic oncology program tumor board, which is done virtually, but once a month it's in person. And then we have a multidisciplinary clinic right afterwards for about a 3-hour period. So between the two, we try to get in as many patients as we can. And the multi-D clinic is virtual. So between the two, we try to get as many patients in to have a multidisciplinary discussion. And it's not possible to see every single patient that comes through UCLA with the lung cancer. But I do think we start to develop our own institutional algorithms of how we handle patients. There's some consistency to it, at least for majority of the patients. So I think it's good to have that discussion. And we're also very heavy in terms of enrolling patients and screening patients for targeted therapy trials and IO trials in the early stage setting, as well as the unresectable stage 3 patients or medically inoperable stage 3 patients. So with the cadre of trials that are available, we're always looking to see what is the best treatment for that patient to complete not only a local therapy but also a systemic therapy, and that could be operative or non-operative local therapy.
So Balazs, I have a question for you now. As a medical oncologist, it's become very complex to pick the best regimen for your patients, and also adjuvant, neoadjuvant, and every 2-3 months there's a new drug, new trial. How do you keep up as a medical oncologist, and how do you do it? How do you do that personalized approach to your patient's treatment.
What I can say is that we grade quickly. It certainly is a challenge, but at the same time, it's so exciting as well. We come to a meeting like the ASCO meeting where we're at, today, and you can anticipate by Monday, Tuesday, when we return, a couple of things will change next week in our practices, and we have to be able to facilitate, those changes to be made quickly so our patients can benefit from it. I'm used to it by now. 20 years of constant progress. It's been just a tremendous time. Now biomarker-driven care for metastatic disease. Now precision medicine for earlier stage. Higher cure rates, and not just higher cure rates. If you look at statistics, we've cut lung cancer mortality by 50% over the last 20 years. 50%. And the curve is dropping this fast. So that improvement should continue. So we need to continue to bring the excitement back to clinic, but we need to rely on each other because that knowledge base is so hard to sustain, and we do rely on our molecular pathologists to make sure we understand the molecular reports carefully, all of our other fantastic supporting specialties to make sure that we get all the steps done right. And we have guidelines, fortunately, national guidelines that we tend to rely on, and a lot of clinical trials in a place like mine at Montefiore, Einstein, and being able to offer maybe the next wave, of new therapies to our patients is just very rewarding, and seeing them benefit from it. But coming back to the patients that we serve, I know that Mary, you're working in a place where many of the patients are maybe socioeconomically more challenged. So maybe the role of the nurse, the navigator, is even more important. Tell us about how you, participate in that multidisciplinary world.
So we're there, the nurse practitioners, the lung cancer navigators, our lung screening navigators, and it is so important to kind of know the plan as we walk the patient down through that pathway, such as if there's a clinical trial or there's a new treatment that the medical oncologist says that this patient would be a candidate for. We need to know that up front because it may change where that patient is seen next. And having that, giving the patient the knowledge about that is incredibly important. So the multidisciplinary team and also our clinical trials team is also at each multidisciplinary tumor board. So they're screening every patient that comes through the door. So every patient, if we have a trial for them, we're talking about that before, at the very beginning when they get their diagnosis.
I just hope that, maybe there's some patients, who will watch this conversation and maybe they can see the excitement that, our heart rate just went up, considering how hard the team works to make sure that individual patient's care is optimized, with the most innovative knowledge that we can deliver. So such an exciting teamwork.
One of the other things, since I know that the population that you work with too, we have a lot of different languages that come through. All of our materials are in multiple languages. We have translators there for them. So when they are getting that diagnosis or we're talking about a treatment plan, they have written material in their language and also translation services for them and their families.